Hi, this is Dr. Bala, and to start with the introduction, I am a teaching faculty with biochemistry. I teach biochemistry for undergrads. I teach biochemistry for students preparing for the MD MS entrance examinations, and I am also a special consultant to a pharmaceutical company which is involved in new drug design. And I'm a consultant, practicing consultant biochemist to standard laboratories and as per the symptoms. Uh, my area of interest like genetics, computer-aided drug designing, CRISPR-Cas technology. So with this backdrop, let me go to today's topic. Actually, before beginning today's topic, we had reports yesterday from our laboratory which said there is a serum sodium value of 109 milliequivalents per liter. So what we do is these reports are called as flagged reports. There's a red flag that appears on the reports. So it is signed by the consultants. So when it came to my knowledge, what I did was I just asked to the practicing consultant, he's from the psychiatrist, and I just called up her and asked, hello doctor, this is from the lab, and we would like to know the clinical history behind this case, this patient. Yes, because it's we are working in a blind setup, we just want to correlate the values before we sign off anything. So 109 sodium is pretty much worrying for us. So just had to make a call, and she gave us a history, and it's a very interesting history and popular. Feedback from my postgraduates, not undergrads. They have been asking regularly for discussion session on electrolytes. So I thought this is a very nice and apt time to make a session on electrolyte disturbances to start with. This is a case-based discussion of typical hyponatremia. And so let us go to the case. Yeah, so here we are. So this is basically my notebook. So I'm having a notebook here, and this is the section, and the section is electrolyte imbalance, and I have pages here: hyponatremia, hypernatremia, hypokalemia, and hyperkalemia. So what I'm going to do here is just going to go about today's topic is I'm going to enter here hyponatremia. So the case history. Let me start with the case history. So 67-year-old male is diagnosed with depression. This is depression. I told her, I told she's a psychiatrist, so she was sent as a psychiatric case. And we saw Sertraline, so Sertraline is SSRI, and is presenting with confusion over past few weeks. And sodium value is 109. That's what's on the table, 109 milligrams per liter. The patient is 70 kg and U volume. Pretty much all data have been given up already. Urine osmolality is 800 milliosmoles. Urine sodium is 40 milliequivalents per liter. He is somnolent, but awakens on sternal rep. So it's like sleepy, but he's awakening on sternal rep. So we just have to evaluate that. So let us first summarize the findings here. I will stick to the lab. So we have sodium of 109. So the normal value is 135 to 145. And he says urine osmolality is 800 millioosmoles per liter. So the normal range for urine osmolality is pretty much wide. Basically, uh, I don't like this much big range to be given for any kind of investigations. I would like to stick with this. This is a common bracket which I see most of the times, but still we'll go for this normal range. And this patient is having 800, so normal, it's normal. And urine sodium is 40 milligrams per liter. So normal range is So what we have here, so we have sodium normal, urine osmolarity normal, and then serum sodium is on the lower side. Okay, so pretty much when you're faced with this kind of a situation as a consultant, and especially people who are finished their MD biochemistry, they have problem on their hands. So before we release the report, we just have to ask the practicing consultant what is basically the clinical history. And supposedly there are situations where they ask us what other panels of investigations needs to be suggested or needs to be taken. So this is a case of, as I told you, this is a case of hyponatremia. So there is something called as hyponatremia panel on based on which type of investigation. So I tell the practicing consultant you need to do certain investigations. The first one being serum osmolarity, and then actually see whenever what I am suggesting is whenever I see a low sodium report, I ask for these things: serum osmolarity, urine osmolarity, and urine sodium. And the fourth one would be this. Many people don't know, but still I like to go with this. I tell you the reason for this: serum uric acid. So this is called my hyponatremia panel. So I see a sodium reports either with the consultant's permission, or sometimes we need to reach them. We let them know the patient, and we'd like to do certain additional investigations in order to proceed with the treatment, which is out of these four investigations. So the postgraduates have to know whenever you see a hyponatremia report, you have to ask for serum osmolarity, urine osmolarity, urine sodium, serum uric acid. Okay, so many of you are very much pretty much you know what is osmolarity. Osmolarity is calculated by formula. It's roughly formula. There is a lot of confusions, but we will stick with this. So it's 2 into sodium plus urea by 6 plus glucose by 18. The normal serum osmolarity is 285 to 295. So anything less than 285 is hypoosmolar. Anything greater than 285 is hyperosmolar. Right. So with this backdrop, now I'm going to teach you a very important methodology in order to evaluate a case history or a case with hyponatremia. This is called as a three-step approach to three-step approach to hyponatremia. Of course, it is known, so it is three-step approach to hyponatremia. So this is how I'm going to deal with hyponatremia. So let us go ahead. The first step is calculate or measure serum osmolarity. Okay. So why I'm telling it's calculated or measured is there are pretty much high-end laboratory setups where we have some instruments called as osmometers. Okay, and postgraduate students, MD biochemistry students, you might have seen osmometers. Many of you might not have seen. In other case where you don't have an osmometer or you have not seen an osmometer, there is always the formula to go back and calculate osmolarity. Just need urea values, you just need glucose values, you need sodium values, right? So now there are three situations here, right? Okay, number one situation is the osmolarity is high. Number two is normal. Number three, it is low. Okay. So I told you already the osmolarity value is 285 to 295. Okay, so where is high? What do you mean by osmolarity? Osmolarity is nothing but the solute content in the blood. The solute content in the blood. And so osmolarity is solute content in the blood means we have already you can see there is urea, there is glucose, there is sodium, and these things are the determining factors. So when there is increase in any of these things, predominantly I would say hyperglycemia. Number two is mannitol infusions. These are the conditions where there is very high osmolarity. These are the conditions where there is very high osmolarity, and there is basically we have hyponatremia. So that I have to tell you, there is hyponatremia plus high osmolarity. This is the condition. Nothing much to worry here. Hyponatremia plus high osmolarity, only two conditions. Now, okay, now let us go to normal osmolarity. I mean, this is hyponatremia plus normal osmolarity. This condition is called as pseudo hyponatremia. Now, this condition is practically very vilified now. It is practically non-existing now because that is when we used to estimate electrolytes before, we used to use a technology called as flame photometry. Now we are analyzing using technology called as ion sensitive electrodes. So this is a artifactual low sodium levels that can be caused by high lipids, especially high cholesterol. Number two is paraproteinemias or high proteins. Paraproteinemias or high proteins. So basically when the concentration of the lipids or when the concentration of proteins increase in the plasma, it can present as a artifactual decrease in the sodium values. So it's just a, confounding bias. So this is practically non-existing now because we are estimating only ion selective electrodes technology. So that is whatever potassium is there, whatever sodium is there, whatever chloride is there, that is going to be reflected. It is not dependent on whether they are worried much about the lipid concentration or the protein concentration. So it's basically an estimation factual error. So these are the two conditions which are predominantly, predominantly associated with hyponatremia and high osmolarity, and hyponatremia and normal osmolarity. Now, the very, very, very significant and notorious combo is this: hyponatremia plus low osmolarity. It's a very deadly combo. Now for this, you need a lot of causes, lots and lots of causes. So this is going to be terrific, and we'll take it to the next step. When this combo occurs, you just have to go ahead and assess the volume status of the patient. Assess the volume status of the patient. Okay, so with this we are completing step one. Now I'm going to take you to the next step, that is step two. I am practically done with high osmolarity and hyponatremia and normal osmolarity and hyponatremia. I'm not going to the details. This is pretty much cooked up combinations there. The only combination which I'm going to worry about is low osmolarity plus low sodium or hypoosmolar hyponatremia. So in that case, I told you we need to assess the volume status. How to assess the volume status of the patient? Now there are three equivalents here. Number one, the patient is hypovolemic. Number two, the patient is euvolemic. Number three, the patient is hypervolemic. So volume, what is meant by volume? Volume is the blood, the components in the extracellular fluid, and it can be basically here I'm worried about solutes and water. Okay, solutes and water. So this hypovolemic can be decreased solutes alone or decreased water alone or decreased solutes plus decreased water. This and this is vice versa. As U volume is normal, is just normal thing. So basically, many people thinking that hypovolemia means dehydration. See, this decreased water component alone is called as dehydration, but there may be decreased solute concentration also. That is also hypovolemia. The decreased solute plus decreased water, that is also hypovolemia. So now, how to assess volume status? This is a very much difficult question. Some people say by physical examination. See, people believe that hypovolemia can be, the dehydration signs. You see the turgor, skin turgor, capillary pressure refill, and all those things. I will see for the signs of dehydration for hypovolemia. And hypervolemia is irreversible, inevitably characterized by pedal edema and stuffs like the Tanasarca, all those things, LI edema, all those things. And then there is a saline infusion test, which is also another way of assessing the volume. Some people take urine output as an indicator of volume, but we are laboratory people. We deal with things like laboratory parameters. So I look for two things. I ask for urine sodium and I ask for urine osmolarity. Okay, so now let me give you some statistics here. The statistics like around 42% of patients admitted in hospitals develop hyponatremia during their course of stay. Okay, so this is the stats here, and so this is pretty much common. And almost 80 to 85% of the cases of hyponatremia are associated with SIADH or simply ADH or antidiuretic hormone. So you all might have known this ADH is a hormone which is secreted from posterior pituitary. Okay, posterior pituitary. And it's coming from hypothalamus, posterior pituitary. It opens up the luminous aquaporin channels where the collecting ducts of renal system, and so it increases retention of water into circulation. So basically it brings water into circulation or minimizes excretion of water into the urine. So there's going to be a lot of pooling of water here that is going to dilute the sodium concentration that is in the blood, and that is the reason for dilution hyponatremia, which is presenting along with SIADH. So that is most of the physicians believe that inevitably. I hear many people telling me, well, when you see hyponatremia, almost always it is associated with ADH. You just go ahead. We assume that this problem is lying with ADH, but then how to differentiate the causes or how to differentiate? Now this is asking for urine sodium and urine osmolarity is step 2. Now I'm going to go ahead and tell you or classify the last step, step 3, which is nothing but finding out the causes of hyponatremia. So I told you, I'm first going to take urine sodium, and next I'm going to take urine osmolarity, And final column, I'll leave it empty as of maintenance. So urine sodium, I told you, we can assume it's 20 to 30. Okay, most of the cases we have here, even though I told you the range is 20 to 220, I'll stick to this range. I'm going to divide this into two. One is okay, so one is urine sodium is less than 20 milligrams per liter. So basically, here is a condition where we have hyponatremia, hypoosmolar. So okay, that's hypoosmolar, low osmolarity, hyponatremia. All the causes which I am discussing are low osmolarity, hyponatremia. Okay, so hypoosmolarity, low sodium, but then there is very less excretion of sodium in the urine. So basically, we are looking at some cause where sodium is not lost in urine, but it is lost through some other mechanism. So basically, this is nothing but extrarenal sodium loss. So the conditions are vomiting, diarrhea, burns, fever. These are the conditions where you have to look at this. Now, coming to this one, sodium is lost so much in the urine. So urine sodium is loss is more. There is only one thing, this condition. So this is renal loss. This is salt wasting nephropathy. Okay, and some people even say this you can primary adrenal insufficiency. At least if you could remember salt wasting nephropathy, I would be happy. Some people also believe that hypothyroidism or some diuretics can cause this, but at least remember this. It's renal and this is salt wasting. Hope I am very clear with urine sodium. Okay, now I'm going to go ahead and explain you about what is the relevance of urine osmolarity. So I told you again, we look at a broader range of 50 to 1200, but here I'm going to stick on with this like this. Okay, so less than 100 milliosmoles per kg, greater than 100. Okay, this is your textbook classification, but I'm not a very rigid textbook person. I'm very practical person. I use different levels for that, but let me explain this first to you. See, we have a low osmolarity, low sodium levels, along with low urine osmolarity also. So there is low solutes in the serum, there is low solutes in the urine, which means there is water present everywhere. It is water is present in the serum, water is present in the urine. So everywhere water is present and it is diluting the sodium content. So this is happening only in one condition known as psychogenic polydipsia. You should remember this, but then there are some people who say that drinking a lot of beer potomania, and there is a diet called as tea to toast diet. These are also, but if you are not remember this also, I'm not worried. I want you to remember this. Psychogenic polydipsia is the reason why we might have a low sodium, low osmolarity along serum osmolarity as well as low urine osmolarity. Now, a critical case where the urine osmolarity is greater than 100 osmolarity. That means the solutes are so much in the urine, or the urine is pretty much concentrated. It can lead to only one thing. It is SIADH. It is SIADH. Okay, it is SIADH. So, oh, I just forgot to add the cliche here. So, causes finding out. This is for hypovolemic. You ask for urine sodium. This is too volemic. case. Okay, just forgot to add that. But anyways, the investigations is giving me that. Okay, so it's invariably SIADH. Some people can also tell that it is secondary adrenal insufficiency. Secondary adrenal insufficiency. So these are basically the causes for euvolemic, low osmolarity, low sodium levels. So this hypovolemic is extrarenal loss or renal loss. You lost a lot of volumes. Basically, you lost a lot of fluids or solutes. Okay, this is a lot of fluid loss. This is a lot of solute loss. And here we have a lot of fluid intake here, psychogenic polydipsia, or there is a concentration of urine happening here. And regarding the last entity, which is hypervolemia, it's very easy. It's congestive cardiac failure, cirrhosis, nephrotic. This cluster you could have seen in many cases. Okay, in all these cases, there is low circulatory volume, which triggers the carotid baroreceptors, pressure receptors, and they send across a signal to ADH to increase ADH activity. So because of the increased ADH activity, what happens is there is a lot of water retention in this blood, and there is it's hyponatremia. There is hyponatremia. Okay, so these are the conditions where we have hypervolemia. So basically, this is our notes. So I'm going again. Okay, and the three-step approach. I'm trying to tell you the three-step approach. The first step of three-step approach is ask for classify based on osmolarity. The second step is assessing the volume status. Okay, this is high, normal, and low. Here we are only focused about low. Okay, number three, elicit the cause. So this is a three-step approach from me to in order to go about how to manage hyponatremia. So sir, you told me manage. So right now we don't stop with as far as our laboratory is concerned. I just call up that consultant and I say that looking at your reports, where is her reports? We are looking at your reports. Let us see here. I will write the interpretation here. There is hyponatremia. Okay, and the urine osmolarity is greater than 100. Okay, and the urine sodium is also greater than 20. Okay, so this comes clearly under the picture of SIADH. It's clearly under the picture of SIADH. Very crudely, sometimes when I teach to my technicians, I tell them only one thing. See, any urine osmolarity, if it is less than 285, it is non-ADH cause. If it is greater than 285, it's ADH. This is only for paramedics, not for your level. Your level, you have to be very systematic and schematic. On proof basis, I tell them, take urine osmolarity. If it is greater than 285, definitely ADH is involved there. If it is less than 285, then it's not ADH. Now, coming to the presentation of hyponatremia. So there is mild and severe hyponatremia. In mild hyponatremia, basically we have muscle cramps, there is lethargy. What I have seen most is there is attention deficit and gait disturbances. So it's basically a locomotor skills which are on the play here. But severe is totally with the brain I have seen seizures. We have seen respiratory difficulties, breathlessness, that is because of the affecting the respiratory system, and obtundation and coma. You know what? These are the findings where we have presentations of hyponatremia. Okay, and finally, let me come to the treatment part. See, the enemy in hyponatremia is not per se the low sodium levels. It is impatient and hurried correction of hyponatremia. Okay, so what will happen is when you correct the sodium too fast, it leads to a condition called as CPN, or central pontine myelinosis. So that is what is basically what we are trying to do here is you will rush solutes into the system. So much hypertonicity will draw out the water from the brain cells, especially the brain stem where the pons is located, and so the the myelin sheath of the pons get destroyed. So this is basically what is happening here, the water being drawn out, because when solutes rushes there, in order to neutralize the concentration gradient, the water will start rushing down from the brain cells into the bloodstream. So that is a specific set of goals. You should not correct more than, okay, and 10 14 maybe. So this should be the correction protocol. So in order to achieve this, what can be given? The treatment is basically nothing but, some books tell it is 1 to 2 mg kg or 3% saline. 3% saline is basically NaCl. Some very roughly you can mention this as 100 to 150 mg 3%. So not mg, single. Okay, so this has to be given, observed for 10 minutes, and if symptoms doesn't resolve, repeat. Symptoms doesn't resolve, then repeat. This is the most commonly followed protocol. And then once the symptoms start settling down, we will switch to, this is a very hypertonic fluid, so we'll switch to hypotonic fluids. And this is the primary aggressive treatment for severe hyponatremia. There are other things, mild managements, mild hyponatremia, how to manage. Number one, restrict water, fluid restriction. See, you know that heart patients, kidney patients, we tell them fluid restriction is a cornerstone of fluid therapy. So restrict water intake. And some people say they can be given salt tabs. That's about 3 mg per dose, maximum of 3 doses. Okay, dose. Okay, number 3, some people say there is a drug called as Vaptans, receptor antagonist, vasopressin receptor antagonist that can be given, and some demoflucycline, all this. But basically, I would say address the cause, which is causing increased ADH. You should be good, okay, with this. Okay, so this is basically what people have to do, and they'll teach you all this in medicine. I'm not going to get into much details on the expert. My role ends with giving the consultant probably this is what you have to look into it. So supposedly the patient, one of my students asked me once, supposedly the patient goes into CPN, what to do? Then you should try and give him desmopressin. It's always advisable to have 1 to 2 micrograms desmopressin in hand when you are addressing a hyponatremia. patient. Don't rush the correction. There are some calculations to calculate the basal rate and stuffs like how come you can correct hyponatremia. Please go back and read. So as of now, so you can say that I have made notes. So even students, UG students can take an essay here. I've started with the case history. I've told you the basic panel which the postgraduates have to order if there is a report of hyponatremia, then how to go about algorithm to diagnose the hyponatremia, what is the presentations of the hyponatremia. Finally, I've ended up with treatment of hyponatremia. So on some another day, I will so on some another day, I will get back to you with possibly electrolyte disorders of yeah, possibly I will get back to you with other electrolyte disturbances like hyponatremia, hypokalemia, and hypokalemia. So that should do. And please do leave your feedbacks and do like our channel and subscribe to our channel for further outputs. And is there any difficulty in understanding? You all can always welcome to leave your doubts in the comments. And is there any topic which you are finding it difficult? Please do let me know so that I have a preparation to be done and the topic can be discussed in detail. Okay, thank you. This is Bala signing off. Thank you again for the time. And hope you all have a good day.